Hello, my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. It is July 2016. I wanted to take a moment to talk about IC treatments. Why? Because I will tell you every single day we get phone calls from patients who just don't know what their treatment choices are. Some are working with doctors who don't have any interest in IC and don't know what to do. Others are working with some physicians who simply treat IC out of old textbooks. And the good news is that in 2016, we have a wonderful 6-step treatment protocol that was invented by the American Urology Association. So I want to take a moment and review this very simple plan with you because I bet it's going to help you see that there are treatment options for you and there is always hope. More importantly, perhaps you've skipped something that actually might be helpful for you. So how is it arranged? 6 steps of treatment. You start at step 1, you do everything in step 1 before you go to step 2. You do everything in step 2 before you go to step 3, and so forth. Why are there distinct steps? Because of your safety. They're putting your safety first. They want you to do the easy, non-invasive interventions before you do the really hard interventions that come with substantial risk. So let's go over these steps. So what is in step 1? Step 1 is the absolute foundation of care. If you're not doing these, you are being very, very foolish because they work for so many patients. Now, the first part of step 1 is drinking water. Listen, it's really normal for patients to stop drinking water. Why? Because you associate water with frequency and you want to be able to sleep through the night. There's a downside to stopping your water intake, and that is your urine gets dark, it gets dark yellow, it gets cloudy, and it becomes much more irritating. It's super, super important that you drink your normal 6 to 8 glasses of water a day to keep your urine properly diluted. If your urine is clear, that means you're drinking way too much water. If your urine is dark yellow or cloudy, that means you're not drinking enough water. Your goal is to have clear, pale yellow urine. All right, so make sure you're drinking plenty of water. The second thing that the AUA wants you to do is to do diet modification, because seriously, if you're still drinking coffee or green tea or soda every day, you are running the risk of not getting better. If you wash your bladder in acid every single day, what is that going to do to the wounds in your bladder? It's going to make them worse. And I will tell you, again, I have this conversation, and it's a really hard conversation several times a week with patients who simply don't believe it. I am telling you to believe it. Your goal is to create an environment for healing. Your bladder is wounded, and if you pour acid on that bladder every single day, the odds are you're going to interfere with healing and maybe even make it worse. Hey, I'm one of those patients. My first year with IC, I didn't know about diet. So what was I doing? I drank a quart cranberry juice a day, not having a clue that that daily acid wash was actually making my bladder much, much worse. And at the end of that year, I will tell you, I was in terrible pain, not from my original onset of IC, but because of the acid washes. I had made my bladder much, much worse. So if you haven't tried diet or you're not doing diet, it is time for you to start doing it. Now, the third thing that the AUA wants you to do is to be relaxed, to relax your muscles. Why? Because muscles that are tight reduce blood flow to the bladder. If you've got tight pelvic floor muscles, that means your bladder is not getting the blood flow it needs. So if you're struggling with muscle tension, you've got to find ways to relax. Whether it is just taking a time out, taking a hot shower, using a heating pad. If stress is an issue, the same thing happens, and you might want to take a stress management class. I took a really good anxiety management class after my diagnosis because I was pretty scared about everything. And I will tell you that anxiety management class absolutely changed my life. Now, another thing that the AUA put in step 1 is the use of over-the-counter supplements. Why is that important? Well, number one, because they work for many, many patients. Number two, they're very, very inexpensive. And number three, they don't come with the side effects that you find in traditional therapies. So there are some supplements that you can use that will help reduce the acid of the foods that you're eating. The most well-known is Pre-Leaf. So we have Pre-Leaf, we have Acid Zap, that's another one, and Javasit is a third one. Those are 3 acid-reducing products. But there are also supplements that appear to help bladder healing, such as Cystorenew, Cystoprotect, Desert Harvest Aloe, or CystoQ. So those are certainly worth you trying because, again, they don't have the side effects that, say, Elmeron would have. And if you can't afford traditional therapies, as many patients can't, your fallback are some of these supplements that were, in many cases, invented by IC researchers. Cystoprotect, which has been the top supplement for more than a decade, was invented by Dr. Theoharidis at Tufts University. And it is, in fact, a favorite of patients because it has a bit of a bladder coating effect combined with a nice antihistaminic effect. Well, listen, you can learn a lot more about those on our website, but just know that they're there. Know that they're available, especially if you can't afford other therapies. All right, so that's step 1. What's in step 2? Well, step 2 contains the traditional treatments that most patients are told about at their first appointment. So that's going to be Elmeron, the only oral FDA-approved drug for IC. The challenge with Elmeron is that it is well known for causing side effects such as hair loss, stomach distress, gut distress, diarrhea, changes in liver enzyme levels. So Elmeron is a bit of a challenging medication for some patients to tolerate. Also in step 2 is hydroxyzine, an antihistamine that is believed to help reduce some of the irritation in the bladder wall. And even a low-dose antidepressant like amitriptyline. You should never be offended if a doctor suggests an antidepressant to you because they're not suggesting it for depression. They're suggesting it because in low doses over time, it helps to calm nerves down. And so using a low-dose antidepressant is viable, especially for patients struggling with pain, but it comes with some pretty significant side effects, such as gaining weight. We call it the Elavil 20. It really makes you start craving sugar, but it also causes dry mouth, dry eyes, and in my case, when I tried it, it gave me a very irregular heart rate. Also in step 2 are bladder installations like the classic rescue installation Heplido A. Listen, it's called a rescue for a reason because it kind of rescues patients out of flares. If your symptoms get dramatically worse and your bladder wall is killing you, one of the things that you can do is call your doctor and ask for a rescue. It's a solution of lidocaine, sodium bicarbonate, and heparin, and what it does is it kind of coats your bladder, but it also helps calm the nerves in your bladder. It numbs your bladder, and generally patients who have a rescue often walk out of the doctor's office being almost pain-free. It doesn't last very long. It'll only last for a couple of hours, but if it's a big-time flare, it can be very, very helpful. There are some other older bladder installations that really aren't used. 2 that are never used now are chlorpactin and silver nitrate. They're not even mentioned in the AUA guidelines, and they're associated with causing a lot of bladder damage and a lot of pain. And then DMSO. DMSO is indeed approved as a bladder installation for the treatment of IC, but it too has fallen dramatically out of favor because it can be painful, it can be irritating. Whereas the rescue installation, patients feel good afterwards. And so doctors tend to prefer treatments that make a patient feel better. So again, I'm not aware of too many clinics that are using DMSO anymore. But also in step 2 is something new, and that is pelvic floor physical therapy. Now, why is this important? 10 years ago, we didn't know that the pelvic floor muscles were badly compromised in IC patients. I mean, we had some reports that they were tight, but we didn't understand how frequent and common it was. And it wasn't until 8 years ago that the National Institutes of Health released a study. It was a multi-center study that evaluated pelvic floor physical therapy for the treatment of IC, and they were staggered by the results. Pelvic floor physical therapy outperformed every oral medication, every bladder treatment dramatically. And that was when the IC movement had to take a step back and go, oh, maybe the bladders are far more involved. I mean, maybe the muscles are far more involved than we realized. And so pelvic floor physical therapy is considered an essential part of treatment, especially at step 2. If you haven't had a pelvic floor assessment, you should go get one. It's super easy. It's absolutely nothing to worry about. And if your doctor says, yeah, your muscles are pretty tight, what they'll do is refer you to a physical therapist who will do a nice pelvic floor assessment. You know, your pelvic floor is like a woven basket of muscles. You've got muscles that go sideways, you've got muscles that go from front to back, and you've got muscles that go from low to high. The goal of that very first appointment with a physical therapist is to find out what muscles are tight. Because once you have their name, and I don't want you to leave that office without the name of the muscle groups that are involved, you can do research to try to figure out what is normally done to help repair that muscle. In my case, I have a torn piriformis muscle in my left hip area. And so my therapy on a daily basis involves working specifically with this muscle. So again, ask for a pelvic floor assessment. It's very, very important. All right, what's in step 3? Step 3 is really about the treatment of Hunner's lesions. You know, Hunner's lesions only affect about 5% of IC patients, but they are often the most serious patients. These are patients who are very diet limited. They're struggling with high levels of pain. They don't sleep through the night. And when a physician looks in their bladder, what they find are these very profound red areas. Sometimes they're cracks of inflammation in the bladder. And these do not generally respond to oral medication like Elmeron. They're bigger. They're profound areas of inflammation. So what we do now, and actually basically this has been done for the last 10 years, is they get treated specifically either with fulguration, that means it's kind of like cauterizing, they heat it up. They might use a laser to do the same thing, or they might inject it with a steroid, triamcinolone, and that actually is the most preferred form of treatment right now because it doesn't leave any scars like the laser therapy or the fulguration would. So a couple of injections of steroid into the middle of the lesion will dramatically calm it down. And I'm really excited to share that we have a new therapy currently in clinical trials called Lyris, or Linka, which is the first treatment in history to actually heal lesions after just a 2-week treatment. Now again, this is still in research studies, but if you've struggled with lesions that do not respond to therapy, you should come to our website and look at those clinical trial listings because this is the most promising treatment that we currently have in development. Again, it's at the research stage, so it's not FDA approved, but it's pretty darn exciting. All right. Also in step 3 is just hydrodistention with cystoscopy. Now, you know, hydrodistensions are very controversial. In the old days, doctors felt that the more you stretch the bladder, the better. So what they would do is take you to the OR, give you some anesthesia, fill your bladder with fluid, and stretch it. And by stretching it, they believed, you know, that would help. I'm not quite sure why they believe that, but ironically, after you have it done, some patients actually feel better, but it's a false sense of feeling better. So how does a hydrodistension work? By stretching the bladder, you temporarily break the nerves in the bladder wall, so when you wake up, you don't really feel anything. You feel better, and it's like, oh, that really kind of helped me. Of course, the problem is that nerves grow back. And sometimes more nerves grow back. And so hydrodistension as a therapy is really not done very often anymore. It's really done more only when the diagnosis is in doubt and when the doctor wants to get a closer look at your bladder wall. Now, one last thing about hydrodistensions, the American Urology Association recommends low pressure, short duration procedures. Again, in the old days, they used to fill up the bladder a whole bunch, really stretch it out, leave it in there for a long time. And when you do that, sometimes bladders rupture, and it's certainly very physically traumatic to those bladder tissues. The American Urology Association no longer recommends high-pressure, long-duration procedures. They want you to do low-pressure, short-duration procedures to minimize trauma to the bladder. All right, that's step 3. Now, what's in step 4? So you've done everything. You've done everything, step 1, step 2, step 3, without any luck, and you're ready to move on. So what's in step 4? First of all, it's neuromodulation. There's a belief that for some patients, their nerves are not functioning normally. And so there's a school of thought that says that if you re-regulate those nerves, they will start behaving normally. And this is done through something called neuromodulation. There are 2 forms of neuromodulation currently in use. One is called sacral neuromodulation, and that involves placing an implant in the sacral area of the spine. It requires surgery. And then there's another one called post-tibial nerve stimulation. That's done at the ankle and requires no surgery. The brand name for that is called Urgent PC. Now, today, given the risks of surgery and the hundreds and hundreds of adverse events filed with the FDA regarding InterStim, most patients start with the non-invasive ankle stimulation first. And ironically, I was one of the very first patients who had it done in 1993, the year that I was diagnosed, by the doctor who invented it. His name was Marshall Stoller at UC San Francisco. I have to tell you that it broke me out of a year-long, very painful flare. I had my first 2 hours without pain at week 4. I had my first day without pain at week 7. And I continue to believe that that very simple 10-week nerve stimulation procedure was very, very helpful to me. But I'm also incredibly grateful that I did not end up in the surgical InterStim group. They were both at UC San Francisco, but it was very traumatic for patients back then. The early days of InterStim were very rocky, very painful for patients. The devices were loose. The devices moved frequently. And in my support group, we had many, many patients who were very traumatized by that. So I thank God that I ended up in the ankle group. And I would encourage you to consider first the ankle group, if not just for the risk of adverse events. InterStim can bill out at over $100,000. Ankle stim generally bills out under $10,000, maybe $5,000. So again, if cost is an issue, that's where you want to go. All right. The other thing in step 4 is BOTOX, botulinum toxin. Now, BOTOX is mostly associated with facial procedures. What does it do? It turns nerves off, so those nerves become inactive. And again, the theory here is that nerves in the bladder for some people are not behaving normally. So what they've been able to do is inject BOTOX into the bladder wall, and for some patients, it helps them. But for other patients, guess what? They can't pee afterwards. It's really scary for them. You know, that is why BOTOX is in step 4. It comes with risk. That is why it is not recommended for patients who are not able to self-catheterize. On the other hand, when the AUA guidelines first came out, it was put into step 5 because that risk of not being able to urinate was very, very profound. But since that time, it has been reclassified into step 4. Why? Because they are using much smaller doses. With the smaller doses of BOTOX comes with fewer side effects. So BOTOX might be an option for you. It's very, very compelling, especially if you've worked through the steps and nothing is working for you. You know, and again, thankfully, I'm going to say that's rare, but it's still an option worth learning about. All right, what's in step 5? Step 5 is really about experimental procedures. Step 5 is basically cyclosporin. Cyclosporin is a very strong steroid that comes with very, very severe risks of adverse events. But the research is very interesting. It's showing benefit for some patients. And in fact, I have a very good friend with pretty severe IC who's doing it, and she's delighted by the results so far. But again, really, you have to take your time to educate yourself about it and learn about the risks. It's not something that you can approach casually. All right, and now we come to the final step, step 6. Step 6 is surgery. And thankfully, most patients never get here. Most patients are able to manage their symptoms with step 1 and step 2. But surgery is a possibility for patients who maybe have skipped treatment, they have avoided treatment, or something traumatic has happened. And I'll tell you the story of an early IC patient that I still know today who had she had her bladder removed. Scary, huh? That sounds really scary, but in her case it was really important. So her symptoms started when she was a teenager, and they were really big. I mean, she was going to doctor after doctor after doctor with constant pelvic and bladder pain. And about 10 years went by, and finally the doctors agreed to look at her bladder through her belly. They agreed to do exploratory surgery. And what they found shocked them. Her bladder had been perforated. And they thought her bladder was perforated 10 years earlier because of a very bad car accident. So this poor young woman literally had a perforated bladder for a very long time, causing very, very severe pelvic pain. And in her case, the bladder was not repairable, and they did remove it. And she is thankfully doing better now. Bladder removal also happens in bladders that get very, very small. We happen to have a bladder removal support forum on our website. Again, in our support forum, it's run by one of our best volunteers who did have her bladder removed, and that is a great place where you can talk with others if you are considering this. But again, you shouldn't be considering it if you're not doing the basics. I can't tell you the number of times people say they've tried everything. They insist they've tried everything, and when I talk to them, boy, yeah, but they're still drinking a gallon of coffee a day. It's like, no wonder they're so bad. No wonder they're so bad. So you have to start with the basics and move your way thoughtfully through the steps. Don't just jump to step 6 and assume you're going to get there, because most patients never get there. All right, there are a couple of other principles in the AUA guidelines that I think are very, very important. Number 1, if a therapy isn't working for you and you've given it a good try, they don't encourage you to keep taking it. What they say is, let's move on. Let's look at other therapies that might help you a little bit better. In the old days, 5-10 years ago, patients used to ask, do I have to take this medication for the rest of my life? And the answer is no. No, you give it a thoughtful period of time, and if it's not working, you move on. If it is working, what you do is after you've improved dramatically, you might slowly get off of that therapy to see if you still need it. That's something that you have to work with carefully with your doctor to come up with a plan as to how to do that. But so anyway, the point here is, no, you don't have to take a medication if it's not working for you. The second point is, and they're very clear about this, is if you're getting worse, if you're not responding to anything, they say revisit the diagnosis. Let's make sure we know what we're treating here. We had for many, many years patients who didn't respond to bladder therapies, and they were a mystery. Well, now we know why. You know why they didn't respond to therapies? Because their bladder really wasn't the dominant problem. The dominant problem for them was their pelvic floor muscles. And so, again, if you're not getting better or you're worsening, let's take a step back and let's revisit that. Maybe you need to have a pelvic floor assessment. Maybe they need to look at something else. It's important to ask. Don't just stay at home and suffer in silence. If you're getting worse, go back to the doctor and let's engage in a good dialogue again. The last concept that the AUA is very firm about is pain treatment. They understand that the pain of IC and a painful bladder can be agonizing. And they absolutely encourage compassionate pain care. They want pain assessed at every doctor's appointment, and they want pain treated thoughtfully, compassionately, and effectively. And so if you're struggling with pain, know that you should be asking for help. You shouldn't suffer in silence. You need to let your doctor know that your pain is interfering with your ability to function, that because of pain, you can't go to work, you can't sit in a car, you can't go shopping, you can't go sit at church. That is the way that you begin that discussion and dialogue about pain care, because most physicians would then say, okay, if pain is interfering with your ability to function, let's see if we can find a pain intervention that might improve that. The American Urology Association also supports the use of opiate pain medication if necessary. Don't be afraid of it. Learn about it. Ask about it. We have a lot more information on our website, not only about all these treatments, but also about what causes flares and pain. We even have a pain management guide that you might find helpful. So if you have any additional questions, please come visit our website at www.ic-network.com.